Oh, hello, everyone. My name is Herman Chique Alfonso, and I'm the Education and Program Coordinator for the Dementia Society of Ottawa and Renfrew County. We recognize the importance of brain health and dementia prevention. Contributions to the risk and mitigation of dementia begin early and continue throughout life, so it is never too early or too late. New risk factors identified could potentially reduce young onset and later life dementia. On that note, this live webinar starts with the question, are sleep disorder a risk factor for dementia? And to solve this question, I have a great pleasure to introduce our speaker today. He's Dr. Elliott Lee. He's a psychiatrist and sleep specialist and director of the Sleep Disorder Clinic at the Royal Ottawa Mental Health Center. So without further ado, I will turn over to Dr. Lee, and welcome Dr. Lee to our Dementia Prevention webinar series.
Thank you very much. Thank you for having me. It's a pleasure to be here to speak with you. I just want to clarify, I don't profess to solve that problem. I just propose to examine it a little bit and see if we can look at some potential relationships. So first of all, I just want to declare that I don't have any disclosures to declare. I don't have any commercial support for any of the data that I'm going to be presenting to you today. So I just thought I'd start with a video first on one of the functions of sleep, which is the glymphatic system. So sleep has a variety of functions, but I think the newly discovered glymphatic system is perhaps of most sublime interest to maybe the group here. So I'm just gonna play this here. This is from Jeff Iliff's group from Berkeley.
Sleep. It's something we spend about a third of our lives doing. But do any of us really understand what it's all about? See, we all know based on our own experience that when you sleep, it clears your mind. And when you don't sleep, it leaves your mind murky. But while we know a great deal more about sleep now than when Galen was around, we still haven't understood why it is that sleep, of all of our activities, has this incredible restorative function for the mind. So today, I want to tell you about some recent research that may shed new light on this question. We found that sleep may actually be a kind of elegant design solution to some of the brain's most basic needs, a unique way that the brain meets the high demands and the narrow margins that set it apart from all the other organs of the body. So how then does the brain solve its waste clearance problem? Well, that seemingly mundane question is where our group first jumped into the story. And what we found as we dove down into the brain, down among the neurons and the blood vessels, was that the brain's solution to the problem of waste clearance, it was really unexpected. It was ingenious, but it was also beautiful. Here, we're again imaging into the brain of living mice. The frame on your left shows what's happening at the brain's surface, and the frame on your right shows what's happening down below the surface of the brain within the tissue itself. We labeled the blood vessels in red, and the CSF that's surrounding the brain will be in green. Now, what was surprising to us was that the fluid on the outside of the brain, it didn't stay on the outside. Instead, the CSF was pumped back into and through the brain along the outsides of the blood vessels. And as it flushed down into the brain along the outsides of these vessels, it was actually helping to clear away, to clean the waste from the spaces between the brain cells. If you think about it, using the outsides of these blood vessels like this is a really clever design solution. Because the brain is enclosed in a rigid skull, and it's packed full of cells. So there is no extra space inside it for a whole second set of vessels like the lymphatic system. Yet the blood vessels, they extend from the surface of the brain down to reach every single cell in the brain, which means that fluid that's traveling along the outsides of these vessels can gain easy access to the entire brain's volume. So it's actually this really clever way to repurpose one set of vessels, the blood vessels, to take over and replace the function of a second set of vessels, the lymphatic vessels, to make it so you don't need them. And what's amazing is that no other organ takes quite this approach to clearing away the waste from between its cells. This is a solution that is entirely unique to the brain. But our most surprising finding was that all of this, everything I just told you about, with all this fluid rushing through the brain, it's only happening in the sleeping brain. Here, the video on the left shows how much of the CSF is moving through the brain of a living mouse while it's awake. It's almost nothing. Yet in the same animal, if we wait just a little while until it's gone to sleep, what we see is that the CSF is rushing through the brain. And we discovered that at the same time, when the brain goes to sleep, the brain cells themselves seem to shrink, opening up spaces in between them, allowing fluid to rush through and allowing waste to be cleared out.
Right, so that's, I thought, a very elegant description of that glymphatic system that's very active and newly discovered and has led to a lot of interest and ideas for how to examine sleep. Because essentially what he's describing is that sleep may function as kind of like a dishwasher for our brain, essentially cleaning our brain every night. So we know that sleep has a lot of connections with a lot of different kinds of symptoms that we experience during the day. I would say at least in our clinic and probably in most literature, these are probably the three most common issues that have been associated with sleep and sleep problems. We generally conceptualize sleep as having a bidirectional relationship with pain, depression, and cognitive impairment. And these things are also interconnected. We've written about how these things can be addressed, but it goes both ways. So certainly people, for example, who are depressed, they tend not to sleep well. But if you don't sleep well, that also increases your risk of depression. And the same can be said about pain problems and cognitive impairment as well. So, there are many other functions of sleep, and it's hard to know all of what sleep does, but what is very clear is what is needed for sleep to do whatever it is supposed to do in terms of its restorative function. And we know that for sleep to function adequately, we need three things to happen. People need to get a good quantity of sleep, a good quality of sleep, and sleep has to occur at the right time. I just want to examine each of these three things a little bit carefully. So quantity is fairly easy to understand. It just means you need to get enough sleep, and if you don't get enough, then going to have some problems. So most adults need between 7 to 9 hours of sleep to function adequately in the day. This is a graph produced by the National Sleep Foundation outlining the amount of sleep that people need. Generally speaking, as we get older, so those adults who are over 65, our need for sleep actually is thought to stay the same, but our ability to sleep decreases. So we may become less efficient sleepers as we get older. And that clearly has implications for functions of things like the glymphatic system. But it's not just a quantity that's important. So we know that there are issues with quantity if people don't get enough. So when people don't get enough, people have compared people's functioning to functioning at a 0.05 blood alcohol level, which is legal limit in most provinces. Even under 7 hours, we can start to see impairments in performance. So what's interesting is when you start to sleep deprive people, the first thing that you can see is cognitive function actually declines, followed by the speed of responses, then followed by accuracy of responses. So this has implications for athletes, for example, like they'll make more mental mistakes first if they don't sleep well, and then their speed will suffer, and then their accuracy will suffer last. And when we see long-term sleep deficits, then we see higher risks of several medical and psychiatric disorders, cardiovascular disease, diabetes, inflammatory markers, and sympathetic activity. So our sympathetic system turns into overdrive when we're not sleeping enough. So, but it's not just the quantity of sleep, as I said, that's important. It's also the quality. So this is just a picture of a symphony. And many people have compared sleep to a symphony, that even if the symphony is long enough, if you don't have good people playing in the symphony or the quality of the audio recording is not good, then even if the symphony lasts long enough, you won't get that same experience if the quality of the musicians or the conductor is not good. But it's not just the quality and the quantity that's important. We also need to sleep at the right time. And this is the more subtle issue that's probably not appreciated by many people. So this picture is just kind of an out of focus picture, but essentially when people don't sleep at the right time relative to their own internal clock, then sleep does not function as well as it could. And so we don't get that same restorative function. So you can see this in any kind of shift worker, for example, that if someone has worked all night and then they try to say, okay, you worked all night, you should just be able to sleep from 8 a.m. to 4 p.m. That's 8 hours of sleep and you should get a good quantity and quality of sleep. We know that, and I don't know if any care providers here have had to do this because they had to stay up all night. It's very difficult and usually impossible to sleep straight from 8 a.m. to 4 p.m. Like usually people go to bed at 8 and they kind of get up around 12 or 1, try to get some haphazard sleep and then, really can't do it and then try to stay awake the rest of the day. They're kind of groggy, but we just know that both sleep quantity and sleep quality suffer if sleep is not initiated at the right time relative to that own internal clock that I mentioned previously. So I just want to mention a little bit about insomnia. So this is really an issue of quality of sleep. Again, if you're just not sleeping enough, we know that as people get older, this becomes more and more of a problem. It's one of the most common sleep disturbances. It affects women more than men. People who are divorced or separated have more problems with insomnia than people who are married typically. Although maybe about 1/7 of the population may be affected, once people get over the age of 65, it can occur in up to 50% of people. We actually saw in the pandemic, 50% of people at the height of the pandemic were actually suffering from some kind of insomnia symptoms. Usually it's sleep maintenance, like difficulty staying asleep at night, but it can also be sleep initiation or just having a non-restorative sleep throughout the night. So how may be sleep related to dementia? Well, there's a lot of data suggesting that quantity of sleep may be important. So this was, now I know there's a lot of lines here, but this was actually data produced by Sabia and colleagues. What is really interesting about this data compared to other previous data that have been identified is they followed a lot of adults here. They followed almost 8,000 adults, ages 50 to 70, and they measured their sleep objectively. So not only did people complete sleep logs, identifying how much they slept over a period, over a huge follow-up period, 30 years, but they also, they looked at their sleep objectively with something called actigraphy, which is, it's kind of a wristwatch device that indirectly can measure the amount of sleep that people are getting. So what we see here on the x-axis is the amount of sleep that people have been getting. This is all groups together, and try to ignore the dotted lines here. That's just sort of the error bar, but follow the black line. And so what they saw in these 8,000 adults followed over 30 years. They divided them into various groups like 4 to 5 hours, 5 to 6 hours of sleep, 6 to 7 hours, and so on. But the fundamental take-home point of this was that when people were getting under 6 hours of sleep at night, so right here, their risk of dementia increased significantly, over 30%. Okay, so in other words, when people were sleeping less than 6 hours a night, they had a 30% higher risk of subsequently developing some kind of neurocognitive disorder. And again, the biggest strength of this study is that it followed a lot of people, like 8,000 people, followed over 30 years, right? Because they started people in their 50s, 60s, and 70s, and then tracked them. So they started basically in the 1980s, and then tracked it until 2010, and then also measured their sleep objectively, as well as with sleep logs. So not only were people documenting their sleep, but they also had a subgroup, which is shown here, following their sleep objectively and showing that as they followed these people and looked at who developed dementia, they were able to predict with higher risk that those who were sleeping less than 6 hours a night had a higher risk of developing dementia, even after controlling for socioeconomic factors, behavioral factors, cardiac disease, and other things like this. So again, there are other data to kind of support this, that basically showing that the less sleep people get, the more likely it is that they may get dementia in the future. So, you know, I've kind of mentioned some of this already, but depending on what kind of data you examine, we know that sleep disturbances may increase the risk of developing some kind of cognitive impairment, but not all studies agree. So that, that one was pretty powerful because of the large numbers involved, but some studies actually don't show any risk. So we do have to acknowledge that. Interestingly, we see that several other studies are showing that when people have fragmented sleep, so that's really a poor quality of sleep, not just the quantity, that we actually see increased deposition of various proteins that are associated with the development of neurocognitive disorders, including beta amyloid, tau, and alpha-synuclein. So these proteins are the pathologic hallmarks for both Alzheimer's disease and another disorder called Lewy body dementia. Generally speaking, most studies will show what we call a U-shaped distribution for neurocognitive disorders and sleep duration. In other words, if you sleep less than 7 hours, now that previous study showed was less than 6 hours, or more than 9 hours of sleep, these are the two groups that are at higher risk for developing neurocognitive disorders. And most people believe that the reason that you see an association with neurocognitive disorders with more than 9 hours of sleep, it probably means they have a problem. Those patients have a problem with their sleep quality, but they're trying to compensate for that with quantity. But that may not be an issue. So that may actually be a problem. So several other studies have also linked benzodiazepine use, a medication used to help with sleep and sometimes anxiety, with the onset of Alzheimer's and other neurocognitive disorders. And we also see that insomnia predicts postmortem artery disease. When you look at people after they've passed away and look at their arteries and biopsies, you can actually see that there's increased arteriosclerosis or plaque development in the arteries of their brains. So this is all kind of like smoke, but very suggestive that there's a fire brewing underneath, looking at the link between sleep and possible neurocognitive disorders. So, in my practice, when I think about sleep issues and what may be associated with dementia, I really see the most common things that I think about are insomnia, which I tried to cover a little bit, and that's just the tip of the iceberg on issues, medication use, sleep disorder, breathing, that's really a big problem, and then also people who act out their dreams at night, something that we call REM behavior disorder. So this is just a list of the commonest sleep disorders we see, especially in older people, something called a breathing-related sleep disorder or obstructive sleep apnea. We also see something called restless leg syndrome, where people have a really uncomfortable feeling in their legs with a need to move, and sometimes they kick or twitch their legs at night. And then some people will act out their dreams, and this is something called REM behavior disorder, but that is actually a hallmark for the development of another kind of neurocognitive disorder. So we'll just talk briefly about these. So when I'm screening for sleep disorders, I think these are the commonest questions that we'll ask for wondering whether someone might have some of these conditions. So for sleep apnea, usually the #1 question is, do you snore? It turns out that's a pretty good question for men. It's actually a terrible question for women because most women actually don't snore, but can still have a lot of breathing problems. But better than the second question, which is usually very important, is does your partner or a caregiver maybe complain about your sleep? And if there's a complaint identified there, it's very suggestive that there could be an underlying sleep issue. So for restless leg syndrome, we ask, do your legs bother you before you go to bed? And does it get better with movement? So people will have this uncomfortable feeling in their legs sometimes, they just have to move, and then they move, it seems to help, and as soon as they stop moving, it comes back. It's usually worst at nighttime. And then REM behavior disorder, our screening question is, does your partner say that you do anything unusual at night? So you're just acting out dreams, punching, kicking, things like this. Or we can ask the patient themselves, have you ever fallen out of bed? Because sometimes the punching and kicking is so violent that they actually will fall out of bed. So I just want to talk a little bit about sleep apnea. So this is defined as repeated obstructions in the back of the throat, the pharynx area, so pharyngeal obstructions, accompanied with airflow cessation, that's what we call apnea, or partial obstruction, which is what we call a hypopnea. It's really measured by an index called the apnea-hypopnea index, or AHI. It's just a frequency of events that a person will have per hour of sleep. So generally 5 to 15 events per hour is considered mild. 15 to 30 per hour is sort of moderate severity sleep apnea. And then people who have more than 30 events per hour is considered severe sleep apnea. So common symptoms we see for sleep apnea, so as I mentioned, snoring, but sometimes they can be sleepy in the day or they can't sleep well at night. Often a partner or caregiver can see them actually stop breathing or struggle to breathe at night. Many of them will wake up with headaches in the mornings. Interestingly, going to the bathroom at night is actually a symptom of unrecognized sleep apnea, especially when people go to the bathroom 3 or more times a night. Turns out that that's actually a predictor for early mortality. Waking up with a dry mouth, because people are often, kind of snoring through their mouth at night. And then memory complaints as well sometimes can be a symptom of unrecognized sleep apnea. And interestingly, irritability or even depression can also be a symptom of sleep apnea. Now, and I would say the ones that I put in the asterisks there are actually the most common ones we see in the geriatric population. So we know that for sleep apnea, the prevalence of this increases with age, and that range for ages 65 to 95, 37.5 to 80%, that's basically like half of people who are over the age of 65 may have some form of sleep apnea. Most people are undiagnosed. Usually when people start to get those symptoms I mentioned, it's just really dismissed as part of aging. Lots of conditions that can increase the risk for sleep apnea, kidney failure, thyroid conditions, obesity, although interestingly, obesity is not a great predictor for sleep apnea in the elderly population. It's better for the younger population, but for older people, not as much. And then I put neurocognitive disorders here as well. One thing we know is that as people get older, they have less muscle tone. In other words, all of our muscles get more flabby as we get older. And this includes muscles in the upper airway. And so that makes them more collapsible. And then menopause also increases the risk for sleep apnea as well. There's something kind of protective about estrogen and progesterone that women lose when they hit menopause. We know that the prevalence of sleep apnea in men to women is generally 2 to 1 premenopausal, but postmenopausal, that ratio drops to 1 to 1. So again, really suggesting that there's something protective about those hormones for women that they lose with menopause. So a screening test that we can also use for sleep apnea is something called the stop bang. So basically, if people have 3 or more of the 8 symptoms, so do you snore? Are you tired in the day? Any observed apneas or breathing events? Do you have high blood pressure? And then the bang is kind of more objective findings, a body mass index over 35 kilograms per meter squared. So there's ways to calculate that over 50. So if they're geriatric, they all kind of follow that. And if the neck circumference is over 40 centimeters, which is about 16 inches for a neck collar, and then especially if they're men, there's a higher risk, but women can still have that risk, especially as they get older as well. So sleep apnea has been implicated in the development of Alzheimer's dementia. So there's lots of data kind of examining this, but I just want to show one study. This was by Casanovo and colleagues from Italy. So this is a whole bunch of images from something called diffuser tension imaging. So this group, they looked, so diffusion tension imaging is just a fancy way of looking at where the water goes in the brain and looking at the water flow, if you will. So they looked at 17 patients with sleep apnea and then 15 patients who were the age-matched controls. And so I don't know if you can see, but there are little bits of yellow here. So everywhere it's yellow in different sections of the brain. So each of these represents a section of the brain. So it's just sliced, down sort of through the forehead to the back of the head and then imaged. But everywhere that there's yellow, there's an abnormality between the patients with sleep apnea compared to the control. So in other words, these are the parts of the brain that are being affected by sleep apnea, the parts where they're yellow. So there's a little bit yellow here in the top section, but there's a lot more yellow in the bottom sections. Okay, so the yellow parts actually indicate issues of more reduction in what they call the white matter fiber integrity. In other words, how well the water flows in the white matter. So in other words, there's something wrong with the white matter, which is like basically the fatty tissue of the brain or the tissue of the brain that does all the things that we want the brain to do. Okay, so more yellow is bad. And so you can see that particularly in the bottom sections of the brain. So these are all of these subjects are kind of collapsed together and kind of averaged here to develop this signal. But the sleep apnea patients have significant differences compared to the control patients. But then when these sleep apnea patients got treated and then they try to subtract the images, so this slide is now showing 12 months of CPAP treatment, we see those yellow sections basically go away, right? So in other words, CPAP, by the way, it stands for continuous positive airway pressure. It's just a mask people wear to kind of keep the airway open. But when patients were being treated with CPAP to treat their sleep apnea, these patients had very severe sleep apnea, by the way, we see virtually complete resolution of the differences in white matter integrity in the sleep apnea patients versus the control. So I thought this is just really powerful data suggesting that sleep apnea might be implicated in the subsequent development of some kind of neurocognitive disorder. Okay, oh, slide is stuck here. Okay, I just want to talk a little bit about REM behavior disorder. Now this affects probably 0.5% of the population, especially older people and people who have some kind of antidepressant use or history of neurodegenerative disease, particularly a group of disorders that we call the alpha-synucleopathies. The most common of these is Parkinson's disease or Lewy body dementia. Alpha-synucleopathy is just the pathologic marker that is used to identify these disorders. So usually we see the onset of this where people act out their dreams, usually in their 50s or 60s. 90% of subjects identified in the literature are male, so we don't know why that is. And what's interesting is when this diagnosis is made correctly, half of these people will develop some kind of Parkinson's type symptoms within 10 years of the onset of the dream enactment. So it's like the dream enactment is an early marker for that disorder. We think that 80 to 90% of these will eventually develop some kind of neurodegenerative disorder, particularly those alpha-synucleopathies, which is a common collection of these disorders. It's about 14 of them, but Parkinson's and Lewy body dementia are the most common, but there are several others like multisystem atrophy, which is less common. But so often when we make this diagnosis, in some ways from an academic point of view, it's interesting because it's a very interesting disorder, but it's also a bit demoralizing because there's a high likelihood that that person will develop some kind of Parkinson's disorder or related condition in their lifetime, but we don't actually know that for certain. So how about management for insomnia? So if we think that insomnia is a risk factor for the subsequent development of cognitive issues, there are certainly things that we can do. So number one is actually looking after what we call our sleep hygiene, having regular sleep and wake time. So remember that sleep is actually best achieved when you sleep at the right time relative to your own internal clock. So the more we can keep that routine, the better. We generally try to avoid daytime naps, or if you have to nap, to keep it within 30 minutes. Just the more we nap in the day, the more likely it is that we'll disrupt that circadian cycle. I suggest people to avoid clock watching at nighttime. So sleep is a funny thing. The harder you try to sleep, the worse it is. So what happens if you look at the clock? Oh, it's 12 o'clock. Why am I not asleep? It's 1 o'clock. I'm still awake. Oh, it's 4 a.m. I only have 2 hours left to sleep. It actually makes you think more about your sleep, and then your sleep can be worse. We tell people to avoid alcohol and caffeine. Those are things that generally sabotage sleep. Really important for maintaining that circadian rhythm to maximize light exposure during the day, and then minimize or ideally eliminate light exposure in the evenings, particularly light from the computers or the backlit screens like iPhones or iPads. There are data showing that prolonged exposure to those screens, particularly with how close they are, can actually disrupt that circadian cycle and essentially trick the brain into thinking it's daytime. It's really important to exercise during the day. I mean, these are things we haven't, it's not, that part's not rocket science, but we know that the more people exercise during the day, they build up a higher pressure to sleep at night. And then if insomnia is still a problem, we may consider something called cognitive behavioral therapy for insomnia and sometimes medications in certain cases. So cognitive behavioral therapy for insomnia involves elements of cognitive therapy, which is basically how you think, sleep hygiene, which are the things I just talked about, kind of like behaviors in sleep, and some relaxation training, so deep breathing exercises and other related exercises to help decrease that overall sense of arousal that sometimes people get before they're going to sleep. So the cognitive therapy is looking at adjusting what we call maladaptive beliefs about sleep. So some people feel like, for example, if they don't get, they need 10 hours of bedtime to get 8 hours of sleep. And so the therapy is aimed at really confronting those distortions. If you try to spend 10 hours in bed trying to get 8 hours of sleep, that's like trying to put a size 8 foot into a size 10 shoe. I mean, sometimes people then can't fall asleep in time, or they get up too much in the middle of the night, or they get up too early. So it's really important for, in those circumstances, for example, to optimize the bedtime just for sleep. So there's a link there to look at cognitive behavioral therapy in more detail. There's several self-help apps that are now available for public use. I put a few there so people can kind of do it on their own even as well. But it's a very effective treatment for insomnia in the absence of any other medical or psychiatric or primary sleep disorder. So I always get questions about medication, so I just want to make a little spiel about them. So in the US, there are 4 medications that are approved actually for the treatment of insomnia disorder. A class of drugs we call the benzodiazepine receptor agonists, but these are colloquially called the Z drugs from doctors. Benzodiazepines, melatonin receptor agonists, these are not available in Canada, and then a new class of drugs called hypocretin receptor antagonists, but now available in Canada. But beyond the approved medications, there are several other non-approved agents that can be effective for insomnia, but are not necessarily FDA approved. And I just listed them there, including even cannabis products, but we've reviewed those in the literature that I cited there. So I'll just make a few comments about a couple of these drugs. So benzodiazepines are actually probably the most widely studied for insomnia. They actually are quite effective. They really help for sleep initiation. People usually will fall asleep within 30 minutes, but they have a lot of adverse consequences associated with them. People have a high risk of having falls, motor vehicle accidents, daytime sedation, even forgetfulness and rebound insomnia. And newer studies are actually implicating chronic benzodiazepine use in the subsequent development of a neurocognitive disorder. But what's not really clear is, while it's known that people who use benzodiazepines chronically are at higher risk for developing neurocognitive disorders, it's not clear whether it's the benzodiazepine use that's causing that higher risk, or is it the underlying condition that's causing their insomnia that they're using the benzodiazepine for that ultimately leads to that higher risk. So there's still some controversy there. So there's something called the Beers criteria, which is a panel of international experts on geriatric medicine. They publish criteria on what medications to use, but their most recent criteria from 2019 strongly suggest avoiding chronic benzodiazepine use altogether in the elderly. Just the aforementioned risks there far outweigh the benefits as people get older, so they actually recommend not using them chronically at all in the elderly population. So there are just some comments on some other of the sedating antidepressants. Trazodone, there's actually very limited data on the efficacy in the elderly, despite how often it's prescribed. Interestingly, some studies suggest it may be helpful in preventing the development of a neurocognitive disorder. So this goes with the idea that if you consolidate sleep at night and allow that sort of dishwasher function to function continuously, maybe you are increasing more waste clearance from the brain, but not all studies agree. Mirtazapine has been shown to have benefit for people with depression and insomnia, but can have significant side effects, including weight gain, sedation, and increases restless leg syndrome and periodic limb movement disorder. Doxepin is actually a very interesting one I just wanted to make a comment on. It actually works through blocking histamine receptors, and actually it turns out it's very specific to histamine. So this actually might have more potential for use in the elderly population in the absence of any medical or psychiatric disorder, because it turns out that although we worry about what we call anticholinergic effects, these are effects of most of these drugs that affect memory, that these anticholinergic effects for this drug is very minimal, and the histamine effect is very specific. So that actually might be a good agent for insomnia in the elderly. So I just want to summarize, sorry, I went a little bit over time here, but we know that sleep plays a role in clearing waste products from the brain, and this has opened a variety of avenues for research about the glymphatic system and how sleep may be implicated in the development of neurocognitive disorders. Insomnia, we know, is very common in the elderly and can also be associated with a neurocognitive disorder developing. Sleep disorders can also be associated, particularly the ones that I mentioned: obstructive sleep apnea, REM behavior disorder, even medication use. So I outlined some screening questions there. If wondering about certain kinds of sleep disorders, things that we can do during the day. Exercise, exposure to light in the day, but not night. Avoiding alcohol, computers at night are probably the first steps for us to having a regular sleep cycle. And then really, if insomnia is a chronic problem, to consider psychological therapies before medication use for insomnia, but also think about those potential for sleep disorders. So sorry I went a little bit over time for what I wanted, but I thank you for your attention. These are a source of sleep interruption for me, but I wouldn't trade that for the world. Thankfully, they're not this young now, so they're sleeping a lot better these days, but I'm happy to take any questions that your group might have.
If anyone does have any questions, you can just type them in the Q&A box or the chat box, and I'll read them out loud for you.
Okay, I'm going to stop the share here, I think, so and try to answer. Oh, he put my link there. Great.
So our first question is, how long is zopiclone, I'm sorry if I'm saying that wrong, safe to use?
Well, so the context totally depends. I will, one of the biggest, I'm thinking about several different issues. So I will tell you that in young people, zopiclone, which is one of these Z drugs, or benzodiazepine receptor agonist, has been studied in people, young people, where people have taken it for actually up to a year and not developed actually any significant problems or addiction issues or things like this. That's probably the longest study that I can think of. I think it was done by a group at Duke. But their group, when they had people on it for a year and they never developed addiction, never developed tolerance, never developed, these things, they kind of asked, well, how addictive could this be if you took the same drug for a year and never had to escalate your use? But in their study, and they had like, I think 500, 600 subjects, they excluded anybody who had a history of addiction problems, right? So they were very careful to screen those out. So, when I look at that study, I think there are people who can use a drug like zopiclone for a year and be okay. Now, on the sort of the counterpoint to that is, just as an example, Health Canada actually recommends not using more than 5 milligrams of zopiclone for people, anyone over the age of 65. It turns out that when we look at studies in older people, then higher doses are associated with all those risks that I mentioned: fall risk, driving risk during the next day, potential for memory problems, that we actually want to keep that dose really low. Now, I know I say that I see so many elderly people who are using higher doses than this all the time, but we also keep that in mind, that for older people, it's probably not good, because older people in general, they don't metabolize drugs as well, so they're more vulnerable to the side effects and potential long-term effects of these drugs than younger people, for example. So I don't know if that helps answer the question or not at all.
She added that I'm in my late 50s and have been on it for 2 years. Not very helpful due to chronic stress as caregiver of dementia parent and separation. Yeah.
So, generally speaking, even for zopiclone use, it's not recommended to use it more than 3 or 4 months in general for any person. But when the question was about safety, again, people have been studied for a year and we're okay. But usually zopiclone is just indicated for short-term use. If you have some kind of stressor coming up, an exam or some event that you have to do, and then you use it for a few days, and then after that try to wean off of it. But it's generally better to try to address the stressor or the cause of insomnia if you can, rather than these medications. Like, basically what those medications do fundamentally is they just raise the arousal threshold that you need to wake up, right? So it makes it harder for you to wake up from your sleep at night. But that also affects how you function in the day, because if it doesn't clear during the day, then you feel a little groggy, in the day. You need to get going, and that's where all the risk comes from for these drugs.
Any other question from the crowd? Well, maybe I have one for Dr. Lee. Dr. Lee, I have a question regarding Lewy body dementia. I know there's been described a lot of problems with sleep or sleep disorders in Lewy bodies. So could you tell us a little bit about this type of problem during sleep?
So Lewy body dementia is one of those alpha-synucleinopathies. So it's just marked by alpha-synuclein, which is the proteins that are the pathologic hallmark of that disorder. Patients with Lewy body dementia, they tend to have more problems with insomnia, and they also will have a higher likelihood of acting out their dreams at nighttime. So this is that REM behavior disorder that I mentioned before. So that could be a real problem for caregivers, because often patients get injured at night, or they're injured the partner, especially if they're sleeping together. So in those cases, once we can make the diagnosis, so one thing that we want to establish, for example, in those people, they actually also have a slightly higher risk for having sleep apnea, but sometimes sleep apnea causes them to act out their dreams. But then if we treat the sleep apnea, then if they have less dream enactment, then that can be an effective treatment. So that's something that we would do as a clinical evaluation. But if acting out dreams keeps occurring, then actually I know I'm gonna contradict myself, but actually the number one treatment for those patients is actually to use a benzodiazepine drug. It turns out it's very effective at suppressing people's ability to act out their dreams, but it's a very tough call because of all those risks that I described, in terms of like fall risk in the nighttime and memory problems and things like this. But people will actually argue both sides of the fence as to whether it's better to have them have consolidated sleep at night, and not act out their dreams so they have more energy in the day, or do you not give them the medication to minimize the exposure to that medication, to minimize the risk of any kind of memory consequences from that medication in the first place. So that's sometimes a very tough call. I don't think anyone has a clear answer for that. But because of those issues, usually our first line agent then for treating those people who act out their dreams is melatonin. It turns out melatonin may be effective in up to half to 2/3 of people. Usually it's 6 to 15 milligrams. So that normally for melatonin to help with sleep, it actually, you actually have to use far lower doses, but REM behavior disorder is an exception where higher doses might be more helpful. But melatonin, the good thing about it, it doesn't have the potential for addiction, really doesn't have nearly as much fall risk as benzodiazepines. And if it works or is effective, then it's quite a reasonable agent to use. So usually we'll start with that one first, just to see if that can be helpful. And then if not, then we have to give consideration to the use of the benzodiazepines.
We have another question. They're wondering if weighted blankets from insomnia are helpful at all.
So a lot of people can use weighted blankets. It really depends on what the cause of insomnia might be, whether the blankets could be helpful. So certain people, for example, people with restless leg syndrome, they can often find benefit. The stimulation from the blanket actually can be found to be helpful, or people who have some kind of hypersensory issues. So people are very sensitive to the environment. Sometimes that extra stimulation can be helpful. I would put it another way. It really doesn't hurt people at all. So I would say if people find benefit, then absolutely, to go ahead and use it. I certainly recommended it for some patients. Where I see it is usually sort of the most helpful in our patient population is those people with pervasive developmental disorders like autism and that kind of those autism spectrum disorders. Those patients seem to really get benefit from that kind of stimulation at nighttime.
I have a question. You had mentioned melatonin, and I was wondering if there's a particular time before going to sleep that makes it more effective, or like can it be ineffective if you take it too early or too late before you go to bed?
Oh, that's a great question. So melatonin as what we call soporific medication, which is a primary sleep medication, is generally not that good. At most, maybe 10, 20% of people will find it helpful as a primary sleep medication. So in other words, taking it just before bed to try to help facilitate sleep. However, there are certain people who have what we call a delayed sleep phase. In other words, they actually need to go to bed later and wake up later, or sometimes we call these people night owls in society. But for those people, melatonin can actually be quite helpful if taken. Usually it's, I think, 4 or 5 hours before their planned bedtime. The rationale for that is kind of complicated. I have some other slides to try to explain that, but it turns out that the brain has what we call a melatonin response curve, where the brain is only responsive to melatonin, or is more responsive to melatonin at certain times than others. So usually the easiest way for us to just suggest that for people is actually to take melatonin at 7 p.m. If you want to go to bed at 11 p.m. or so, take it at 7 p.m. Over time, taking melatonin at that time may shift the circadian cycle to make it easier to fall asleep. And ironically, smaller doses are better than higher doses. If people take too much melatonin, like people say, well, 1 milligram didn't help, so I take 5, and 5 didn't help, I take 10. While it's not toxic, what ends up happening is melatonin is still left over in the brain. And then it turns out if you take melatonin in the morning, so if someone took melatonin at 8 a.m., they'll actually impair their ability to sleep the following day. But what happens if they take a high dose of melatonin at 7 p.m.? It turns out that there's still what we call spillover melatonin left at 8 a.m. Then it's like just taking 2 steps forward, going 2 steps back, right? So, a smaller dose of melatonin, usually 1 or 3 milligrams, taken at 7 p.m. can be helpful for some people who are especially prone to that, what we call delayed sleep phase, can actually help them fall asleep. The physiologic amount of melatonin we have in our brain, it's like 0.3 milligrams. So like even 1 is just a huge washout for our brain. So I see people trying 5 and 10 and 15. With the exception of the REM behavior disorder, which is a little bit different, these doses are just mega doses that are actually probably for most people a little more counterproductive than helpful, especially when taken at nighttime.
Thank you. There's another question. Is there anything that is not a prescription drug that can help you stay asleep at night, or is that melatonin?
So, it really depends on what the cause of insomnia is. So, like I get this question kind of a variation of this question. It's like, I don't care about what's going on with their insomnia. Just, doctor, give me the drug that can help them sleep at night. Well, I think evaluating insomnia is like evaluating chest pain. Do you really want, morphine will work for most kinds of chest pain, right? But do you really want to give morphine to someone who's having a heart attack? Probably not, right? You want to get them to the hospital and, get their heart checked out, or someone who's, rupturing their aorta, and that's why they're having chest pain. So it really depends what the cause of insomnia is. So once you determine that, then you can pick the appropriate treatment. Are there certain drugs that can help in certain issues that cause insomnia? Yes. There's probably an effect for some people who, like, for example, if pain is a problem causing insomnia, then even cannabis products, might have some benefit, because there may be some benefit for pain. We still need more data. Depending on the potential etiology, there may be some roles for other agents. So I mentioned melatonin already. Like if allergies are an issue, then like antihistamines, can be even helpful, for example. But by and large, I should say that there is no known surrogate for good quality sleep. Like anything that we do that we think keeps us more awake and substitutes for sleep, it's really just masking sleepiness that's already there. Like the only thing that we know that does the things that sleep does is actually sleep. So I'm not really a big proponent of over-the-counter substances for sleep. the data was like very few exceptions is, you know, very sparse for those things. You know, I'm trying to think. I will say there are some anecdotal reports for magnesium being helpful for people with restless leg syndrome, but even that's really anecdotal data, but there's definitely some patients who identify that as a benefit. So, but again, it really depends then on what the cause is rather than, you know, just picking an actual agent.
Another question is if someone did need an appointment with a sleep specialist, how would they go about connecting with one?
So there are several sleep clinics in Ottawa. So the Ottawa Hospital has one. West Ottawa Sleep Center is another one. Our hospital, obviously, the Royal. There's also one at Montfort and one at the Queensway Carleton Hospital. And there's several in the outlying areas as well, but those are the 5 major ones. Really, it's just a referral from any physician. So it can be family doctor, internist, psychiatrist. We even get referrals from walk-in clinics for some kind of assessment. And then once a referral is received, then that person will get an appointment. Some sleep clinics, they will actually do the sleep study first and then maybe see the patient. Other clinics like ours, for example, we see the patient first and then determine whether sleep study is needed and then go from there. So it's just a different way of doing things. Both approaches have advantages and disadvantages.
Right, so I think we could wrap up. So thank you, Dr. Lee. Thank you for everyone for joining us today. And I don't know if, Chelsea, do you have any comment or anything else?
So thank you everyone for tuning in. This September, you can join the Dementia Society Brainy Active Challenge of 2021 by doing a brain boosting activity every day for 30 days and help us to ensure that no one faces dementia alone in Ottawa and Renfrew County. For more information and education programs, you can visit our website, dementiahelp.ca, or register to our weekly roundup. Have a nice day, everyone.
Thank you for having me. Everyone, please get good sleep.
Thank you, doctor. Bye now.
Bye.